Yeah.
We might start. There might be some latecomers around, so don't get in their stares. Good evening, everyone, and welcome to this event of the Australian Institute of International Affairs Queensland branch. My name is Graham Kerridge, and I'm the Secretary of AAA Queensland. Firstly, I wish to acknowledge that we're holding this event on the traditional lands of the Turrbal and Yagara people, and we pay respects to their elders, past, present, and emerging. The land on which we meet has been a place of discussion and storytelling for millennia. I wish also to acknowledge the support of Hannah's List, who very kindly have been opening their premises to us to hold our events. We're immensely grateful for their support. Now, a challenge across many countries, Australia included, is to ensure that we have enough healthcare professionals to provide the care that the community needs. As all of you will know from your own experience, Australia has been relying heavily on foreign trained professionals in healthcare, and shortages of health professionals creates a major constraint in the services that can be provided. However, it's critical for any country to look at ensuring not only an adequate number of healthcare professionals, but also to look at how their skills are used. Health professionals work within well-defined scopes of practice, and that's a good thing for ensuring safety and optimal care. However, as in any field, the nature and the technology of healthcare is constantly changing, and the scopes of practice that were defined in the times of Florence Nightingale may no longer be optimal and need to be regularly reviewed. Tonight, we've got Professor Lisa Nissen, the Director of the Centre of Business and Economics of Health at the University of Queensland, talking. She has been a prominent health practitioner leader, an educator, researcher, and implementation scientist, nationally and internationally for more than 25 years. Lisa is a fellow of the Society of Hospital Pharmacists of Australia, the Pharmaceutical Society of Australia, the Hong Kong Practicing Pharmacists Association, and the International Pharmacy Federation. Her work is focused on learning from international settings, the use of workforce to how to reform workforce scope of practice, and particularly for allied health, nursing, and pharmacy professionals. This reform offers a critical opportunity to optimise the domestic and international workforces and to improve patient outcomes. So Lisa will talk for about 35 minutes, after which there'll be an opportunity for questions. So please welcome Lisa.
Thank you. Thank you, Graham. Thank you, everybody, for having me. I've got a lot to cover. Graham sent me some tough exam questions to put in my presentation and to really include some things around the international space, the things that we can learn from there, and particularly how we use some of our international medical and allied health and nursing workforce within Australia. I'd like to also start by acknowledging traditional custodians of lands, the Yagara and Turrbal people, their elders past, present and emerging, but particularly in the context of the talk today, I think to acknowledge that they were our first healers and health professionals in the country and their contributions to their community and their healthcare outcome. So I want to cover a few things today. I want to talk a little bit about the current system that we're in and have a look at our workforce and how it's constituted. And I think Graham touched on some of the things that we hear and see in the media around the pressures on health and healthcare and the influence that workforce has on that. But it's probably good to have a look at what our workforce is and how that's constituted. Have a look at scope of practice and what that kind of means in the context of our health professionals and what some of those future opportunities look like. As Graham touched on, I'm a pharmacist by background, so my clinical training was in pharmacy, and I do a lot of work in systems and policy and practice reform. I'm not an economist, no hard economic questions. I'm good with policy. I know some smart economists, so I think what we see in the headlines every day are things that are similar to this. We see a lot about ramping in hospitals, that we should have more ambulances, more paramedics, and more things to improve the efficiencies that we have in the system. But I think what we see, particularly with the ambulance conundrum, is that it is actually a system issue. It's maybe how we deal with people in primary care to prevent them getting to hospital. Maybe it's how we discharge people from hospital that mean that people shouldn't be ramped at the front of a hospital. So maybe it isn't about having more ambulances. But what we see is the fact that people get stuck on a ramp and maybe there aren't ambulances to turn up to people in the community who need them. We also see that we may be in a situation where we won't have enough health professionals if we continue to operate the system as we operate it now. And we don't think about how we look at efficiencies in the system, either in how we utilise our current workforce or how we think about the integration of things like AI and digital into the system to improve how we might use our workforce, but how we might care for our patients. These are things that many of us might know. Australia, on balance, based on many of our comparator countries, does reasonably well GDP-wise with regard to expenditure on healthcare. It's around about 10% at the moment, fluctuated slightly above that a couple of years ago. But on balance, we're not spending a huge amount on healthcare compared to, say, our American colleagues. But the risk as we get older and we have an older population, we're using more expensive technologies and medical and medicine interventions, is that the expenditure that we have on healthcare may start to increase. We have a lot more chronic disease in the population, some due to lifestyle, some due to ageing population. We're living a lot longer than we used to. But the conundrum that we face is the fact that we have less people, our birth rate is lower, we have less people on balance to look after the people that are older. So across the workforce, but particularly in the health workforce, per capita, we have less people available than we did 20 years ago to look after the people that are ageing and are facing the needs of healthcare. So if we look at the workforce itself, the health workforce, we see that there's shortages, we see it in the news, we hear about it pretty much every day, but we have an ageing workforce. So from a health point of view, we have an ageing health workforce as well. And we'll see that when we look at some of the specific workforces. But we also have a distribution problem. We have a very metropolitan workforce where we don't have as many of our workforce in regional and particularly rural and remote areas. We have issues with our training pathways. Over time, our training pathways have gone from 3 years to 4 years to 5 years to 6 years to 7 years. So some of that has been about, as Graham touched on, the difference in scope of practice, the requirements around capacity and capability, the increased technical and cognitive demands of those jobs. But that also means that the training pipeline takes a long time. If you see a headline that says we need another 15,000 doctors, that's a 10-year, 15-year pipeline to get those doctors. So we need to think about what our training pipeline is, but it is currently a pipeline that has a lag to it that we need to think about. What we found, particularly post-COVID and during COVID, is the wellbeing of the workforce is significantly declining. So what happened during COVID was there was a bit of a hurrah period where everybody went, yay, health professionals, thank God for you. But then the health professionals realised they can't wear pajamas to work, at least on the bottom, sit in front of a computer and have work-life balance by working from home. Their colleagues, particularly people leaving school and going into careers, found that they had work-life flexibility, they could work from home, they could pivot around what their families were doing. If you're at the coalface of clinical care, you have to go to work. And so that shiny glow of yay, health professionals has become much more of a burden on the health workforce. And we've seen a lot of people leaving the health workforce over the last few years, and the attrition and retention has become a lot more of a consideration and concern. We have no strategy. So we have no national workforce strategy for the workforce. So we have some strategies for individual workforces, which I'll talk about in a little while, but we have no overall national workforce strategy. or health. So I did touch on this just now, but we have 120 different workforce policies, but none of that consistently points to a plan about how we're going to think about our workforce as we go into the future. And so while we're getting headlines that say we don't have enough workforce, we need more workforce, we need other workforce, going to Graham's point about how we're going to configure our workforce, how we're going to put them together, how we're going to deal with the challenges, how we're going to use them across the continuum of what is the healthcare workforce, there is no plan currently. And this was only yesterday. This was, I think it was Courier Mail. Tim Nichols, Queensland health worker shortage worsening. The predicted need is 46,000 health workers for Queensland Health alone by 2032. And you can see across the range of people that Queensland Health is expecting, noting that they are thinking they will have some new facilities over that time, 21,000 nurses away. Now, out of all of the facilities that are graduating people across Queensland in that time period, you will not get that number of people that are coming out. So what are we going to do for workforce? So this is out of the Queensland workforce strategy. Some of the things I wanted to point to, there won't be exam questions on this, but we have an ageing workforce. So within the next 10 years, 20% of the workforce will reach retirement age. So we have an older workforce. So there's a good and a bad thing to that. So for Queensland, it's sort of mirrored around the rest of the country. People tend to stay. You can see down the bottom, the turnover rate is actually quite low. So in the metro and regional areas, it's around 5%. So people stay. They don't tend to leave, and they're an older workforce, but we're going to lose about 1 in 5 in the next 10 years. We have a growing demand for the services, so about 17% demand growth. We're going to need more workforce, but we have an ageing workforce that's going to take some of that corporate knowledge, experience, mentoring, all of these new people coming in who's going to provide that service.
Lisa, I'm sorry to interrupt, but to me it's a bit out of focus. Anyone else experiencing
the slides? Oh, yeah.
It's not very sharp.
That's better. Is that better? Yeah, that is better. Okay, thank you.
Sorry.
No, that's all right. And again, the projected workforce growth, ambulance services, not surprisingly, nursing is large, and this is across the whole workforce is large. And so it's a 30% increase overall in workforce growth. So that's a lot. And again, if we got all the people coming out of all the health programs across all of the institutions, we wouldn't be meeting this demand. So what I want to show you is this is national health workforce data that shows some of the growth across the last 10 years for different practitioner groups. What I want to show you is that allied health, which includes pharmacy, physio, OT, psychology, it's grown as the largest group in the last 10 years. And it has the largest FTE per population. So it's grown by 67%. So that's been the biggest growth group. Nursing and midwifery is definitely the largest group of health practitioners. And we would know just from our general understanding of health that nursing is kind of everywhere. They're in all of the different spaces and they're our largest workforce. But what we should know here, and this is an interesting point, it's kind of maybe a little bit blurry, but the FTE per population of general practice has hardly changed. And that's really interesting because they have the smallest growth and their FTE has primarily been maintained by international medical graduates. So the growth in GPs has not come from trainees coming from the Australian system. There's been a significant decline in the interest in general practice as a career. Subspecialisation and specialisation in general practice has been in medicine has been the largest growth areas. GPs not so much. At this point in time, it's tracking towards around 10% of people wanting to do general practice as a career. And again, the growth in some of the other allied health groups, you can see some of the groups like physiotherapy's grown quite a lot, OT's grown quite a lot, and even my profession, pharmacy, has grown in the last 10 years. So just looking a little bit more at the specific workforces to give you a sense of where some of our international graduates, people that have come from overseas and maybe trained here or registered here, play into what some of this workforce looks like, particularly for some of our larger workforces. So if we look at nursing, we have about 330,000 nurses, 20 that are dual qualified nursing midwifery, and about 6,600 midwives. But most of them work in the public sector. They mainly have clinical roles, and they're mainly in metropolitan areas. So again, that maldistribution, people mostly in metro or smaller metro centres. They're an older population too. So 42 years is the average age, which is older. You think, oh, all the nurses seem really young. They're not. They're older, and they're staying in the workforce, but it's a very feminized workforce. So a lot of people work part-time. What is interesting is 43% are born overseas, but most of them are Australian qualified. So while they may have come from overseas or been born overseas, they've studied here. So 20% of the workforce for nursing, and it's a growing proportion, have come as overseas qualified people into Australia and then registered. And they are one of the major groups, I'll show you in a couple of slides, that have had people come from overseas into the Australian market in the last 10 years. So if we look at our medical workforce, and I can touch on this with our GP practitioners, we have 122,000 medical practitioners, 33,000 of those are GPs. So when you kind of think of general practice across the whole of the country, and you think about the small towns and others, major metropolitan areas, getting into a GP, 33,000 is actually not a lot of GPs. Our medical practitioners generally work 50-50, public-private, 40 hours per week is the average hours for our doctors, and again, very metro. And again, an older population, 45 years being the average age. But this is slightly different to our nursing colleagues. You can see that almost 60% were born overseas, and a slightly different proportion that were qualified in Australia. So you can see that a number of them, as we talked about, particularly with our GPs, have come in as international medical graduates into Australia.
So they would have been qualified in Britain, New Zealand, or one of the other countries that we recognise.
Yep, there's lots of countries that so we get a lot of people from the subcontinent as well. So there's lots of pathways for them to come in.
So there's no barrier anymore.
Well, there's different pathways. So if you come from New Zealand, Canada, US, UK, South Africa, there's a more expedient pathway than maybe if you come from some of the other countries. There might be different exams that you need to take to qualify. Some of the English requirements might be different as well. So I just want to show this because workforce is complicated. So when we talk about needing 46,000 more ... It's not quite as simple as saying we're just going to train some more, because the training pathways are complicated. And this is an example of the medical workforce planning structure. So at the middle of it is this part where, to your point about where they might come from, medical schools train our medical students, but there's a structure around how that happens. And then they get launched out into their pre-vocational training, they are registrars, and then they go through some of their specialty or general practice training. But all of this process is influenced by funding, support for training through the Commonwealth, funding activities around how those actual professions are funded, and then how they deliver those services in state and territory organisations. So that whole sort of conundrum about how many you're going to have, where they might work, how they might be supported, I can be trained and competent to be a pharmacist, but how I might actually go about doing that in practice is affected by funding, legislation, regulation, local credentialing, the people I'm working with, etc. So this just forms one sort of tiny bit of how people then go on practice. And then when we look at what's happening with the medical workforce itself, is that they have an over-reliance currently on locum, international medical graduates. It's being affected by subspecialisation, drawing people away from some of the standard pathways. And they have an oversupply of some specialties. I know that sounds mental, but they have some specialties where there's just too many. Where they have an undersupply of some, and we saw them in the news in the last few days. They don't have neurologists, they don't have gynecology services in Metro North at the moment, and they have issues with generalists and people in rural and remote areas. There's about 350 towns where pharmacists are the only medical practitioner that's available. Don't be afraid, that's okay. But you know, so you would think that maybe there might be a GP or some other provider. So when we then look at where our overseas trained people come in, training isn't really enough. It then comes into these other factors around how we recruit and deploy them, how we look at regulation, and that comes into the pathways that we might bring them in, and then what we do to retain them. Because there is a demand on the workforce, people can pick and choose where they go. If the conditions aren't good enough, if they don't have accommodation that will support them, if they can't support, you know, for a feminised workforce, which health is becoming now, if you are a young health professional that's got a family and you don't have good healthcare and childcare available for your family, no good schools for them, you're not going to go and stay in a regional area. So there's a whole system that, you know, becomes a part of the issue around how we support workforce working in different areas, as we would with any workforce. So with our internationally trained health professionals, there are a number of things that they can use to come in, from temporary skills shortages. So there may be some pathways for some of the specialties to come in through a temporary skills pathway, or through a nominated employer pathway, for example. But there's lots of different rules, different timelines, different age limits, different time limits for how long you can stay. And some have pathways to residency, some don't. There's a number of different categories, and there's been a review of a number of those in the last couple of years, specifically around health. You can be on the skilled occupation list. Sometimes they're not on the skilled occupation list. There's a whole pile of sub-criteria for these, but there are multiple pathways for health professionals to get into the country. But you also need to then register or be recognised as a profession in the country. And this is where the extra barriers have been in place for people. So you can get a visa to come in, or you might be sponsored, but then you have to then register to practice. And so what has been an issue is for some people coming from some countries that could take a number of years. Some of our medical colleagues have, when they're going through the specialty colleges, having issues with the exam process, then getting placements, having supervision becomes quite difficult for them. In pharmacy, in my profession, there's different countries that are recognised as PODMAC countries and others. For people coming, say, from Canada or the UK, it's a very fast process. They just have to do a period of supervised practice and pass some law exams, whereas people that might be coming from, say, China would have to do a much more intensive knowledge test, and then they would have to have supervised practice for maybe up to a year. And that makes it quite hard if you're kind of coming in on a visa, you don't necessarily have an income that's reliable, and you have to do supervised practice for a period of time. So there are fast-track concerns that people had, and so National Cabinet quite recently said you've got to make it better, you've got to make it quicker, we need health workforce to be available. And so there's been a number of processes that they've put in place to do that. In July 2022, over the preceding 12 months, they have had 42,000 health professionals come in to the country, including doctors, nurses, midwives, and allied health. So it is a pathway, the international health practitioner pathway, that is well accessed and well used. Australia is a very interesting immigration pathway for people coming from other countries for all sorts of reasons. 50% of all doctors who registered in the last year were overseas trained. And it's similar for pharmacy. We had 1,000 pharmacists come through the overseas training pathway. So 1,000 graduates out of pharmacy schools, 1,000 registered from international pathway. So this is something that has got better, and we've seen an increase across the health profession. There's been a couple of reviews, interesting and unusual facts you can take away with you for your next dinner party, but there's been two major reviews, the Crook Review and the Dawson Review. This stuff keeps me awake at night. The Crook Review was specifically around efficiencies with APRA, the registration scheme for health practitioners. I know Paul's not here tonight, but he's one of the masterminds of the Crook Review. It was around expediting training pathways, particularly for some of the professions, and looking at some of the English language requirements. Different professions had different requirements and different requirements for supervised practice. And most recently, the Dawson Review has looked at some of the complexity of APRA. It is just a death machine once you get into it, around the differences between different professions and, this one and this one. So they're trying to harmonise things around codes of conduct, expectations for practice, complaints pathways, and integrating some of the things, particularly around different practitioners and how they enter into the scheme. So this is making it better, and it will affect how our international trainees and practitioners come into the system. So, scope of practice. Why is it important? Another test question, this picture. If we think about health as a really important part of the social determinants that we have in society, education, good quality healthcare, economic stability, health is a really key cornerstone to that. And if you wear sort of a political lens and you think about, Tim Nichols going, yes, we've got to do something about, our workforce. We need to improve access to healthcare. It's very important that the health system inputs are able to be efficient and effective. And so the leadership and governance of that and the health system resourcing is a key lever for governments particularly. And so scope of practice becomes a key pillar of that, because it is a way that you can look at resource allocation, how you can look at adjusting to population need. If you can, throw in a different type of way of delivering a service or a different group of practitioners, or you can do things more flexibly. You can impact the health service and therefore feed back directly into the social determinants. And so that becomes really, really important as a lever in the system. And then it all flows on to the outcomes around efficiency, continuity of care, access, etc. So when we talk about scope of practice, and I think you pointed to this, Graham, is it's about your competence, so what you're trained and competent to do. But it also has two other factors that are really important. It's about what you're authorised to do. And so this is where we run into the jurisdictional issues around what you can do in Queensland versus what you can do in New South Wales. So there is legislative and regulatory components that affect this. So I can't do the same vaccinations in Queensland New South Wales can't do the same as we can in Queensland, which is mental, because I'm still a pharmacist and I'm trained and competent to do things and I'm accountable to it, but the legislation says I can't. Crazy. So that's how it kind of plays out. Accountability is around practice standards, code of conduct, and your guidelines for behaviour. So scope is important because the population requires us to be able to use all of our skills that we're trained for. It's stupid if pharmacists are just sticking labels on boxes, because we spend 4 years training them at university and I have another year when they get out in practice. And if that was all they were doing, that is such a waste of all of the resources that we put in the field. So we're underutilising our health practitioner workforce. Depends on how you measure it and how you look at it, but it can be up to 40 to 50% of what they're trained to do we're not using. So all of it is about improving the costs and the outcomes and the efficiencies in the system and getting better care for the people that are at the end of those processes. So we've learned a lot about scope of practice. We did a big review in the last 2 years with Mark Cormack for the Commonwealth Government, looking at optimising scope of practice for providers, particularly in primary care. We looked a lot at what we could learn from other jurisdictions about what using people to their full scope of practice can do. We learned a lot from Canada about using umbrella frameworks, which are designed to look at overlapping scopes of practice in legislation and regulation. So remember I said it's a problem that I can't vaccinate in another jurisdiction like I can here. What they do is they say, okay, well, if you're trained to do something, we legislate or we regulate depending on the province based on that skill. So saying, well, the nurse can do it, a pharmacist can do it, a doctor can do it, whoever has met that competency can do it, as long as there's a governance framework about having all of the other things that make it safe. And we learned a lot around how they use it for things like pharmacists vaccinated, increases uptake, increases convenience, and they use that legislation and regulation to bring in a number of other health practitioners. Digital integration, we learned a lot about how, particularly in a number of other provinces, like BC, they've now got an integrated health record that they're implementing that allows the connection across acute care into primary care and some of their First Nation health services to allow patients to have carriage over that on an app, but have direct integration into that system. From the UK, non-medical prescribing, they've been doing it for over 20 years, yet we can't manage to organise ourselves to do it in the same kind of way. Lots of evidence that it reduces wait times and improves satisfaction around care. They also have advanced clinical practitioner roles, embedding those people into multidisciplinary teams to improve access to care. So you can first contact practitioners in these advanced roles, particularly the primary care trusts. In New Zealand and the US, nurse practitioner independence. I don't think we fully utilise nurse practitioners in this country. We've got about 3,500 nurse practitioners after more than 20 years of having them. So we've failed them by my measure. We haven't really given them appropriate access to resources to function appropriately in the system. Community paramedics in the US, we were talking about paramedics before we started, being able to have expanded roles, not only in the community broadly, but particularly in regional and rural areas. We tie them to ambulances here. Unless they're tied to an ambulance service, they can't really do anything outside of that. So being able to reduce ED visits, for example, being able to provide care to somebody in their home or in an aged care facility and not having to put them in an ambulance and taking them to an ED and then having to wait for 12 hours to have some kind of community-based procedure that they could have. In New Zealand, a lot around nurse practitioners, pharmacists integrating into primary care teams, incentivising team-based care and funding models for that, and a lot around culturally safe care for Maori and Pacific Island people. So a lot of things that we learned about, some of the things that we are already moving towards here and trying to do with some of our models of care, but lots of evidence to say that optimising people's scope of practice can make big impacts in the system. So lots of lessons for us. Regulation based on skill, not title, using blended funding models, interprofessional care and using digital infrastructure, prioritising rural and underserved communities better and thinking about how you can do place-based planning for care and needing that culture and leadership change. If there's not a preparedness to do stuff, you'll end up just doing the same silly thing over and over again and expecting a different change. So some examples, things that I've been involved in that were lessons learned. I think Graham touched on some of these. I had the pleasure of being involved in Australia's first pharmacist vaccination pilot, which feels like a lifetime ago, but just over 10 years ago. It did cause a war with my medical colleague friends at the time. So when we started it, it was like people were going to die on the street. It was all going to be an apocalypse. But I'm sure many of you have been vaccinated in a pharmacy since then. We do about 50% of all the NIP vaccinations in the country now, millions and millions and millions of them. So 10 years down the track, it's okay. The other work that we've done more recently, which we actually made a mistake, well, it was good and bad. We implemented it during COVID, which was pharmacists being able to provide short course antibiotics for UTIs for women. All the GPs shut, so it was quite convenient that we implemented the project during COVID when that happened. So that happened with the UTI pilot in pharmacy. Now it's permanent across the country, and we've now expanded to 23 conditions for pharmacists doing, I guess, what we call minor conditions or common conditions, and that's now a national piece of work as well. So I think those kind of things are lessons learned. Minor ailment schemes have been in place in New Zealand, Canada, and the UK for a long time, and we've been able to learn from how they did it, what kind of conditions were most suited for pharmacists to do, and we've been able to lever off that. So, future opportunities. Because we have a changing demographic, we have technology and AI is an issue for us that we have to see on the horizon, and how that's going to affect how our health workforce is going to have to change and consider how it works. We need our policymakers to be scenario planning and future planning for what that might look like. And we have to work together in an interdisciplinary way to do it, because consumer demand is going to change how health works in the future. People are already voting with their feet. The use of technology, the choice of who health is received from, and how people get their healthcare is very different. The way that people have been driven to receive healthcare over decades and decades, people are just choosing not to do it that way. They're picking the people that they have a trusted relationship with, who they want to receive at the time that they want to receive it. So they're not kind of prepared to take the models of care that we've provided for decades. So we need a workforce that's going to be adaptable. It's going to be digital, fluid. It's have to be proactive to change. So my own workforce is very threatened, I think, by AI and digital. If you're a community pharmacist and you're not moving to service-oriented models of care, so taking up these new opportunities and thinking about the clinical role that you have, and you're really wedded to the technical task of sticking labels on boxes, it's going to be dead really quickly, because robotic dispensing, you dispense a script in 5 to 7 seconds. It's very accurate, and AI will take away a very significant knowledge component, the technical knowledge component, not so much the consolidated knowledge required to be applying it, but you hold in your hands the stuff that I learned at uni in big textbooks. So we can't compete with that. We have to be very proactive about how we apply knowledge to particular things. Soft skills become really important, and we have to be really committed to lifelong learning. So organisations are going to have to be really resilient. They're going to have to be very adaptable to that change. I think the problem is organisations are a little bit like the Titanic. And so we're still wedded to, these big buildings with big infrastructure, and, it's not really like that. Healthcare has to be more flexible. And we have to empower our people inside of the institutions and organisations to be able to be the things here. If we keep sending them down through the standard models, people will vote with their feet and they will go. We need people to be in our organisations thinking about skills-based approaches to how we use our workforce. We've got really highly trained people who are leaving because they can't use the skills that they're trained for. We have to address AI and tech, and we need leadership. We need leadership in organisations. We're not going to change things unless people are prepared to change. And the infrastructure has to change. We need to be able to think about the design that we're using. We have to think about the systems that are thinking about the environment and data. And we have to think about what kind of scenario planning will help us to best put forward something that's going to be ready for the next 10 to 20 years. Because at the moment, we're stuck in the 90s without healthcare. And so it looks really complex. On one side, my colleagues at the universities are thinking about, how we can deliver things flexibly. We can think of how we can get people who want to switch careers. People, like I've been a pharmacist forever, but people are looking at having 4, 5, 6 different careers. How do we pivot, a paramedic to come back and be a pharmacist, to be a physio to be a nurse? How do we start to take people from different careers, not only in health, but other places, and pivot them into health? How do we take people that are retiring and bring them into the health and social care workforce in some way? It may not that you're going to go and do your endoscopies, but maybe you're going to come into the social care work. Maybe you are, I don't know. But, maybe it's coming into the health and social care workforce in another way. How do we integrate all of these different things into innovative learning models? It's not sage on the stage standing giving a lecture. It's much more applied and case-based learning. So we make these people who are really ready to launch out into the workforce, and then we put all of these barriers in the way that prevent them from actually going about doing it. Prevent them from doing person-centered, collaborative teamwork that people trust. And so we have this way that we're doing things now where we think about the hat somebody's wearing. So they're wearing a doctor hat or a nurse hat or a pharmacist hat. And then we make teams based on that rather than thinking about what skills they bring to the table. And so what we think is that we should build the system differently. We should be thinking that we look at the need in the community or in the place or in the service. And then we think about what skills you might want. And then based on those skills, you deploy the people that can contribute to those skills, acknowledging that it might be more than one hat that can contribute to the skill. Because at the moment we go, here are all of your hats. That's what you can use for your system. And it doesn't work. Because the assumption is that you start with one hat or 2 hats and they have to do everything. And we're not using all of the hats that we can possibly use. And so when we're looking at how we plan for the unmet need over here, there's a whole pile of things that actually go into the workforce requirement. What patients prefer, how people are using healthcare, and that across a population or even a local area, that can really be different based on who's there. Maybe it's a really young population, maybe it's an older population, maybe it's a mixture, maybe it's got culturally and linguistically diverse community, maybe it's a First Nations community. So it's not going to be the same everywhere. And then the workforce on the other side, what their capacity is to contribute will be a mixture of not only who's available, but how they want to work. Young people don't want to work 60 hours a week. They want to work, Monday, Wednesday, Friday, between, 9 and 3. Maybe. But maybe they don't want to work the same kind of way. And then a serious consideration is the composition of the workforce. So then how do you composite those people to give you a supply of workforce? So the problem that we've got is that we determine much of this now by legislation. We say, you can do this, you can do this, you can do this. Doesn't matter what you're trained and competent to do, we determine it by legislation. There's a real role for that risk-based regulation. And we don't really think about scope of practice at all. We need to understand more about who can do what and how we can deploy people into the system to do things better. So I'm going to show you an example. It's indicative, please don't use it as fact. But if we were thinking about something like managing diabetes, and you go to a community, Roma, St George, this is where we've been doing some work, and they have a need for diabetes care in the community. And at the moment, this is kind of a hat-based approach. We say GPs diagnose, GPs or nurse practitioners prescribe, pharmacists dispense, podiatrists do fit care, and dietitians give advice. Now, if you don't have a dietitian or a podiatrist or a nurse practitioner, you're left with these two people in your community, maybe, who could do care. But actually, if you start to say, well, it's not that black and white, it's not just that rudimentary about who can do things, and you start to say, well, actually, there's some gradients in here. Pharmacists, for example, I'm not pick on my own profession, actually have some ability to pick up whether somebody's got a diabetic foot issue or needs some referral on to somebody else or does some wound management in the pharmacy. We know that our RNs and our MPs do other things with regard to diet advice, mental health and foot care. So maybe we start to think about how we configure what services are available in that community and what the workforce might be able to contribute to the diabetes care in a different way. So we start to think, what is the need? Who can contribute? And how you can configure that, and maybe then support them through financial models, team-based models, or even legislative and regulatory. So we move away from the model where we fight about patients like chips on the ground, and we actually start to work together based on the need that people have in the community. Because to be fair, the fee-for-service model drives fighting. It's like, no, they're my patients. No, they're my patients. Actually, no, you're my healthcare team. Please don't fight about it. You know what my care is. I want to work with the person that is the right person with the right skill at the right time that I have a relationship with. And I want to be at the centre of that care. And I want to acknowledge that there's overlapping skills and capabilities in the team. And we want those people to work together. So sometimes those people will have shared care, and it's not just one person providing care in sequence. So it seems like it's a bit crazy, and maybe it is. But the Australian Primary Healthcare Reform, for example, is looking at this seriously. So to facilitate it, like I said, we need money to be different. We need digital communication to work so that if I do something, I can upload it so the GP can see it. Because at the moment, they don't see it, so they don't trust me. It's that simple. There's not a trust level that's built by a shared understanding of what's happening in the patient. We need different models of care that optimise what we do. And at the moment, the payment model doesn't really make that happen. And we need that leadership and culture change. And so the scope of practice review was one of about 27 reviews that were happening around workforce, primary care and models of care. And what we've got out of a consolidation of that is a view that, particularly in primary care, we've got some opportunities with some of the initiatives that they're looking at around improving access. So ways that we can get more practitioners going to different places and having experiences, particularly in regional and rural areas. But down on the bottom here, we've got better ways to expand scope of practice, enhance the digital support for the team, and to fund teams to work together. And these are active initiatives that are happening right now. So the key things to finish up are that we're going to have to work together to do it. It needs a resilience in the system for the change because the paralysis in the system to change and the status quo is significant. The existing models of care have been in place for decades, and we need to change because we can't continue to provide healthcare if we stay doing it the same way. We will continue. The modelling that the Queensland model is based on is increasing the proportion or the number by, I think, 5% increase overall. It's not taking into account different models of care or how we use health professional work. It's simply increasing the population by a proportion. So that's fine if you do the same thing over and over again. Definition of stupidity. But you will continue. There is a chance that we don't need 46,000 more health practitioners if we do things differently, more efficiently, and we work together to get a different outcome. So I'm not into eating elephant slowly or one step at a time. I don't think health can wait. I need the healthcare system now and in the future. It is a long-term proposition, but I think there are short-term things that we can do to make a difference. Thank you.
My goodness, it's almost where do you start after a talk like that? So questions, please. Who would like to start off?
It was a fantastic presentation, one of my favourites. So with your advocation for the expansion of scope of practice, which seems reasonable, efficient and feasible, why do you think there's a reluctance to perhaps extend this scope of practice other than maybe safety concerns?
Money.
And money, okay. Well, that was a quick answer. And I also want to ask further, do you think maybe the reluctance or reservations around the scope of practice is due to some policy formulation or implementation, or maybe a lack of legislative innovation other than financial resources?
Well, I think a number of those initiatives have come from, I guess, election commitments or policy windows. So I think they've been through an opportunity to demonstrate a pilot, collect evidence, show that it doesn't have safety concerns, that there are clinical outcomes and patient outcomes that are beneficial. So it's not for lack of evidence or safety. So I think the lobbying that has come, the lobbying for the policy window to open or the election commitment has come from evidence from other countries of safety and benefit. So we've used evidence to say, could we have a chance to collect evidence here to show that it works in Australia? So I think there has been some, it's taken some gumption to make policy decisions against an unpopular view that it will cause people to die in the street and antimicrobial resistance will end the world and, all those kind of rhetoric. But it's been based in evidence. It's been a reasonable proposition with minimal risk to do them based on international. So I think that's where international evidence has been really valuable. We've not come and said, we're going to have pharmacists doing endoscopies, because there is no evidence of that anywhere else, and that would be a really ballsy kind of political decision to do that. And then I think to your point around, I did quite offhand say that it was money, but it's turf war. It is about the view that pharmacists doing those activities take what is called low-hanging fruit out of general practice. So the vaccination was definitely low-hanging fruit, and same for UTI. So it's a short consult. And then we said, well, isn't that good? Naively, first time I went in, said, isn't that a good thing if we take the vaccines out? You've got more time to deal with complicated patients. That wasn't a good thing. I learnt my lesson. Don't say that. It's like, well, we like the fast turnover things. So if you can remove and that's the point there, if you can incentivize teams and outcomes and you remove the competition over you're taking my patient, then you can get a better outcome. Yeah.
Thank you.
The questions.
Is there a need to educate the general public to accept a competency-based skills approach that's been more efficient?
Yes, I think so. I think not for everybody. I think where people have had an opportunity to see lots of different practitioners for different reasons. Maybe there's an understanding that I could see an EP or a physio or an OT or whatever for different things. But I think where people have had, like my mum is 90, her model of care is the doctor. And I'm like, Mum, but like the pharmacist could do some stuff. And she's like, oh yeah, but like maybe I should see the doctor first. So it's the model of care that Mum's known, and she kind of accepts that the pharmacists could do vaccinations now, but it's taken 10 years to sort of come to that idea that that might be okay. But I think if you've had one model for a really long time, I think, and I think that's probably in my recent experience, some of the media stuff that ends up in, you know, full-page ads in the Courier Mail or, you know, whatever that says, you know, people will die if a pharmacist does that. It's not helpful to the education process of saying, well, actually, these other people can contribute to healthcare. We're just really angry that it might take away some of the, you know, remuneration for certain things in our profession. They're actually very competent health practitioners and we trust them. So I think you're right, that sort of understanding that lots of people contribute, you know, to healthcare would be helpful. But people that have had a particular model of care for a long time are to shift.
I'm wondering about, you said about COVID brought about a change of lifestyle, and you also mentioned about the feminisation of the profession, or the professions.
Yeah.
But you also mentioned about an oversupply of specialists. And at a personal level, I had a dermatologist for many years, and then trying to find someone afterwards, I would bet they're in an oversupply area, because there are so many women who only want to work 1 day a week.
Yes.
Is this how do you help address that, Lisa? It's really
No. I think you pointed to a number of things. So over like the last 20 years, there's been more women that have come into health professions broadly. And so there's lots of artifacts that come with that, is that you get at a certain life stage, you get people that step out to have kids, and so they come back in part-time, or they work part-time at that point. So you see in a certain age period in the data, like a part-time workforce. And so accommodating that, I think nursing's live with that, and midwifery's live with that forever. So there's a lot of lessons to learn from nursing and midwifery, and I think medicine, you know, pharmacy, which was more male-dominated, is now a very female workforce. So, I mean, the average pharmacist is a 30-year-old Southeast Asian female, basically, is the demographic of our workforce. I think if you go back when I graduated, it was a male, generally probably Greek or Italian background, maybe first generation, and that was the background, maybe 40-year-old. So it's changed in 30 years to that completely different demographic. And if you look at the hours people work now, because it's a younger workforce that's coming in, because we've had an increase in the number of programs that offer health. So when I started, there was 6 pharmacy programs. Now there's 19. And so that's great because we've needed more workforce. But that also means if you've got more women that are coming into the university programs, the proportion has been just jumping up in that last sort of 20-year period, and they want to work part-time. And so one FTE graduate doesn't end up as one FTE worker anymore, let alone the changes in the millennial work mode, which is different. So they don't want to work full time. So, you know, one worker, I think I was reading recently, is about, you need 1.6 or 1.7 FTE to give you one FTE worker. So that becomes a problem when you're starting to say, oh, well, you're graduating 200 pharmacists, but you're not actually getting 200 FTE in the workforce. So it's a problem.
I ask one final question?
Yeah.
You know how are there colleges, say the College of Dermatologists, and how do they determine how many will enter the field? I don't understand.
You're going down the rabbit hole. You've heard of the word cartel. They do. The colleges determine the training numbers. and that's part of some of the reviews that have been going on lately through the ministers and through the board, is how to look at the training numbers for some of the specialties that are smaller and in need. If the training places are like 50 or 100 training places in a particular specialty, but we need a lot more, kind of self-fulfilling prophecy. It keeps it in demand, which means that you can charge more and it's more in demand, so it keeps the prestige level up. Whereas, if you've got a lot of them, so it's not the only group that do it. So
one last question.
yeah,
Yeah, I've always been amazed that I have to wait 6 months to make an appointment with a dermatologist.
Yep.
When in fact this state has one of the highest rates of skin cancer
Yep.
in the world, I'm told. But anyway, my question is, first of all, I think your presentation must have taken your whole career to prepare. That was a very impressive presentation, I must say. I'm fascinated by this idea of shifting from a role-based model to a skill-based model. And in my mind, when it comes to regulating all of that and shifting from one system to another, what we're probably going to end up doing is we would have choices as to how we make sure this person has the skill. You're either going to do it at the institutional level where they're taught, or you're going to do it at the individual level, which is probably very expensive to do. And so the concern I have is that you're regulated at the institutional level, at the university where they're being trained, and they were taught this skill. But part of having a skill is practicing that skill, and so they were taught to have that skill. But now, 3 or 4 years later, 10 years later, they're given the right to exercise that skill.
yeah.
That
So the way that
concerns me.
works now is, so the programs of study at the university are accredited. So you're correct. So a graduate launches out. So like I launched out an accredited program 30 odd years ago. But my recency of practice is regulated through the Pharmacy Board, which is a Commonwealth group. And so each year I am checked that I'm trained and competent to work in the area that I say I'm working, and I get audited on how I've maintained my competence in that area.
So it's an individual.
Yep.
That's what it's.
Yep. So each year our re-registration is how that is checked. Yep.
Okay. We better draw it to a close now. Look, I'm sure that I speak for all of us that to say that that was a really astonishing talk, Lisa. So thank you very much.
Thank you.